So first off, could you just give us a bit of your own background in oncology?
Yes, I trained as a clinical pulmonologist in pulmonary and critical care medicine at Massachusetts General and at Harvard. And during the research time of my fellowship, I got involved in lung cancer immunology and immunotherapy at an early stage of immunotherapy. When we first began to have the tools to treat patients. And so as a pulmonary and critical care physician, we spend a time diagnosing lung cancer. And I recognized back then during my training that I really had a desire to do something more than just giving patients the news that they had lung cancer. We wanted to be able to do something for them. And so at that time, during my fellowship, we first had recombinant IL-2 available, and so that is the T cell growth factor. We were able to develop trials in which we grew lymphocytes from patients' tumors and to give those patients back their own lymphocytes. And those were the very first trials of tumor-infiltrating lymphocyte therapy, in which we treated patients with melanoma and renal cell carcinoma and lung cancer. And some of the patients with renal cell and melanoma had phenomenal anti-tumor responses, but not in lung cancer. And so those first phenomenal responses in patients in response to something I was working on in the laboratory really drove me to begin to ask questions of why lung cancer patients weren't included. And so when I came to UCLA as a faculty member to start a research program, the questions were, first, why do lung cancer patients not respond? What is the nature of immune suppression that may limit the therapy for lung cancer patients? And second, over time, how does lung cancer begin? And is lung cancer recognized by the immune system early on? And so now, of course, we've come to appreciate that there is immune therapy for lung cancer that works, and it's been transformative for the field, but most importantly for the lives of patients with lung cancer. And as we move along, we're very interested in potentially moving this kind of therapy earlier and earlier on in the course of the disease. And that leads to both the importance of early detection and something we call interception, and that is catching cancer in the lung at the very, very earliest point of the disease so that we can intervene.
So through your own research on lung cancer, what have you discovered with regard to how early lung cancer develops?
I think the most interesting thing recently that we've found that may be highly relevant to patient care is the fact that the immune system begins to recognize abnormal cells in the lung as being foreign and cancerous very, very early on in the process. And at the same time, the immune suppression that we've seen in later disease begins at the cellular and molecular level at the site often to begin to decline. So in other words, there is this battle between our bodies and those very early cancer cells that begins at the very earliest time point. So learning as much as we can about that process then opens the door and the possibility that we can use that information to take care of patients.
So how could this research possibly apply to other areas such as COVID-19?
Right, so one of the things that we're learning in the pandemic as we study COVID-19 is that first, the experience has been is that patients who are at risk for lung cancer, those that have chronic obstructive pulmonary disease or other lung diseases that involve inflammation, may be particularly at risk to do poorly. And that poor response may relate to that inflammatory process. And so what we're beginning to really study in detail is how that inflammatory response then dictates the ability of the virus to enter the cells that line the lung, then to proliferate within the cells and cause damage. And we think that those kinds of studies and sort of the basic science of how that might work could help us help those patients who are particularly at risk because of the nature of their lung disease.
So looking at the COVID-19 pandemic, how has the pandemic altered lung cancer research?
Well, I think all of research for a time was slowed. And now we've been able to, using risk mitigation for our staff and researchers, begin to start again. And I think that people are very much concentrated on doing the right thing for that mitigation, but at the same time making progress because lung cancer is not going away and the severe problems that we're addressing in research are critical and urgent.
So moving forward, how do you think this pandemic will continue to impact lung cancer research and cancer research in general?
Well, I think that there's several ways in which the pandemic may influence lung cancer research. I think that lung cancer occurs within the pulmonary environment, and that environment is very complicated. It involves an organ that is constantly protecting itself from the environment and in a sense protecting itself from our own immune systems, not to go too far in fighting an infection or something that's foreign. And so this inflammatory process that maintains what we call the homeostatic health of the lung can be actually co-opted by diseases, and particularly lung cancer. Lung cancers begin to utilize the immune suppressive mechanisms that our own bodies have in place to protect our organs. And so there's a constant interplay between the ability to fight infections, for example, and have immune surveillance against lung cancer, and the protective forces of the immune system, that is to turn down what we call cell-mediated immunity so that we're not hurting ourselves each time we have even a minor infection. What we're seeing in COVID-19 is many of the patients with COVID-19 pneumonia have this inflammatory response that is overwhelming. And so what we study and learn about the nature of inflammatory induced lung injury can be relevant for our understanding of lung cancer and how we turn on effective cell-mediated immunity against specific foreignness or antigens within lung cancer cells, but don't hurt the rest of the normal lung. So I think there are things that we're learning as we go along that we can learn in parallel and begin to understand more about the pulmonary environment relative to both lung cancer and COVID-19. I think the other aspect of this is that I think there are overlaps in the patient populations who are underserved. And so one of the things that we're aware of in Los Angeles is that the pandemic in some sense shines a bright light on the fact that many of our communities are underserved. There's racial and economic disparities right outside our front door. And so we take very seriously the fact that although we're a great public university and like to talk about that, oftentimes our public is not well served. We live in a county in which there are 100 languages spoken. 65% of us don't speak English at home. Nearly 1 in 5 of us are below the poverty line. We have major causes of premature death. Lung cancer is amongst the top 10, but other things involve, suicide, homicide, motor vehicle accident, alcoholic liver disease. And so many of the things that we need to do, we haven't yet done adequately. And so I think this challenges us then to both look at the pandemic and things that have happened in society to shine a light on racial inequities, to say, we're going to actually not do business as usual. We are going to concentrate on the inequities that exist, not just in the world, because some of my colleagues are interested in global health and the students go to other countries. But 15 miles from my office in Los Angeles, life expectancy falls by 15 years. So I think our first obligation is to our community. And this renewed interest very much relates to our research. And an example of that is that lung cancer screening, a system by which patients at risk for lung cancer have CT scans annually, was really started by my colleague at UCLA, Denise Aberle, who 20 years ago began a trial called the National Lung Screening Trial. She convinced the authorities at the National Cancer Institute and others nationally that it was really important to understand if we could screen for lung cancer, detect it early, and make an impact. And that study, first published in 2011, was probably the most impactful study of our generation. And the reason is it caused a 20% reduction in lung cancer mortality and launched screening for lung cancer, not only in the United States, but essentially with other studies that confirm this around the world. So the difficulty with this, of course, is the implementation of lung cancer screening throughout for the people who need it. And we've only gotten a start for that in all of our communities, but specifically in underserved communities, screening rates are very close to zero. And so it's our obligation then to bring all of this to everyone and to make a dent, to serve as a model for how we would do this, not only in Los Angeles and California, but perhaps around the world. And why do I say that? Is that our county in which we live is the most diverse county in the country, and therefore likely the world. And how we approach this in our population matters, I think, for everyone else. We know that if we look at lung cancer death rates in the United States, they've fallen a little bit the past couple of years, and that's a good thing. But in contrast, if we look worldwide, that's really not the story. So there are 1.9 million cases of lung cancer deaths per year in the world. 2.2 million new cases. And for the last data we have, between 2007 to 2017, that has increased 37%. So we're doing well, but we're not doing well globally. And the numbers suggest that this is by far one of the leading causes of death in the world, and certainly the leading cause of cancer death. And so the challenges before us is, as we work on understanding the very beginning of the disease and ways in which we may creatively use that both in advanced disease and for interception and early detection, we have an obligation that's writ large both in the United States and in our own communities. But we have that as an obligation to determine what we can do for everyone.
So, do you think clinical trials will begin to focus on treatments that can be performed at home as a result of the COVID-19 pandemic?
Well, I think more and more that that is a goal, and our colleagues are doing much more by telemedicine. We've actually part of a movement to really make it much processes more smoothed out in order to have phone consent, for example. And so I think that there'll be many things now that were previously done only by having individuals come repetitively to the clinical setting to have that be able to do done at home.
So that's all I had for you. Is there anything that I didn't ask that you think is worth mentioning in this space?
Well, I do think that it's important for people to know that we need more research, certainly of all kinds, and that how we treat people today is a function of having done research leading up till now. And that's certainly true for what's going to happen in the future. And the only way that we know what care is valuable is to use evidence-based care and begin to use our knowledge and all of the data that we have stored in the data warehouses from the electronic medical record to help us make predictions about what we might anticipate will happen for each of us. And so medicine as it's practiced reacts. We react to problems. We generally don't predict them. We have the information now to begin to do that. We can't really think of, for example, risk for COVID-19 or risk for lung cancer as being a simple matter. We can't really discern yet outcomes from these diseases, and not only their beginning, but how they might end. And so I think that we need to actually all of the resources that are available to marshal together the informatics resources to be able to create the platforms that will let us use the living textbook of medicine that's inherent in our own data. Very importantly, we need a workforce to drive that work. And that will take sophisticated individuals who understand data science and biology and medicine to do the work and work alongside us. So there's a lot left to do. It all relates to having the resources to do that, including funding from generous partners such as Stand Up to Cancer. But it requires us to have a mindset that, in fact, we are solving these medical problems. And at the same time, the academic medical world has as a responsibility for our social good. And they're not separable, but it's a huge challenge. And we're taking that as an opportunity to do this research and make things better for everyone.
Absolutely. Well, thank you so much for taking the time to speak with me. I really do appreciate it.
Thank you. Thanks so much.